we already have the next speaker, Professor P.K. Rajiv. He's going to be talking about a very interesting topic, which we always have problem with. It's about managing PPHN in India, and of course in the lower and middle income countries. So over to you, Professor P.K. Rajiv.
Good morning to all of you. Am I audible?
Yes, you are. Yes.
So first I must thank the organizing committee of IAP Neocon, and I specifically thank my old associate, Dr. V.C. Manoj, who was with me in Amrita in 2002. That's almost 20 years back. So can I have the first slide? Yeah, this is a basic to understand the physiology of normal transition at birth, in which the first breath recruits the alveoli, followed by improved oxygenation. And as of now, we know the latest about cord clamping from Kataria and group. So the transition, the first few minutes to half an hour, determines a lot of the pulmonary vascular resistance, which fails to drop or to be normalized in that period. So normal transition, the pulmonary hypertension has resolved over the last half to 1 hour. And in abnormal transition, you have persistent pulmonary hypertension of newborn, which can be triggered by asphyxia, hypoxia, acidosis, hypothermia, hyperviscosity, atelectasis, and lung disease. Next slide. Now, what we should know is that when we assess by Doppler and echo, we should know the normal values of the pulmonary vascular resistance and systemic vasculars with age, so that once we have the background data, we are able to assess that the pulmonary vascular resistance is increased. But suffice to say that towards late, in early term and late preterm, the pulmonary vascular resistance and systemic vascular resistance change dramatically, so that birth becomes a normal physiological response to normalizing the pulmonary vascular resistance. Next slide. Next. So this is from Satyan's diagrams. We have a mnemonic also: TTN, aspiration syndrome, CDH, high membrane disease, pneumonia, sepsis, etc. Next one. And this is just a pictogram of the same. Please proceed. Now, we have 3 classical pathways of where to interfere with the pulmonary vascular resistance. The first is the endothelin pathway. The second is the L-arginine nitric oxide pathway, in which there is guanylyl cyclase and GMP, cyclic GMP and GMP. The third one is arachidonic acid pathway, prostacyclin and prostacyclin analogs, IP receptor. So all these 3 control the pulmonary vascular tone in a very intimate fashion. It is not like A plus B is equal to C. I was fortunate to study the second part, that is the nitric oxide and the sildenafil pathway through CGMP, I think for last 20 years. Next one. So this is a historical walk through almost 20 years. So you can see that endothelin receptor antagonist bosentan 2000. My work with sildenafil in Amrita was 2002. At that point in time, I did not know the entire spectrum of sildenafil. But as the more I read about this molecule, the last 20 years, it becomes more and more interesting as the days go by. So the green one is all endothelin receptor antagonist. The gray one is the prostanoids, the IP receptor, etc. Mainly, we should be focusing more on iloprost and treponestil, and the older one is ipoprostanol. IP receptor antagonists have not come in yet, but they are in the experimental phase. This Riosigut and Selenex Vipac. So with this background, let us go forward. Next slide. This is the timetable of all the studies which have occurred in the last 10 years, starting from in a chronological order. Let's say we started 2002 with my research work on Sildenafil. Exactly 4 years later, Baccaro and group in South America with Augusto Sola, they did a huge study on oral Sildenafil. The other studies all showed us a trend in how to interfere with the pulmonary vascular resistance on the 3 classical pathways I mentioned earlier. Next slide. So this research work was exactly 20 years back, April, May 2002. So it's a historical walk back to 2002 when we really did not know what was the long-term effect of Viagra, because there was a huge array of complications starting with retinopathy, then stroke, and there was concerns of liver dysfunction and so many other complications which at that point in time had not assessed completely because it was used as a rescue. Next slide. So I was invited to the Hot Topics in Washington, D.C. to give my data on Viagra, and it was well received. But the government of India had prevented me from publishing this because it was at that point in time seen as an experimental therapy. But it came out in BMJ 2002 as a case report. Next one. So I was quite impressed with this statement in the last, I think 2007. Is this the new nitric? So I just kept it just to pep up our talk on Sildenafil. Next slide. Next slide. Now, the whole question on why we are so desperate to find an alternative to nitric oxide comes from the fact that all the world experts find that 30 to 40% of neonates don't respond to nitric oxide. So there's a distinct necessity to find another molecule or a combination of molecules to treat pulmonary hypertension in refractory PPHN to INO. Next slide. Next. And all these logistic problems also come in. It's a very costly gas. And please don't change slide. I believe from the statistics, only 45 centers in India have nitric oxide, whereas there may be around 450 centers in India doing at least level 2 to level 3 care, dealing with very sick babies with PPHN around. So there's a huge requirement to have a magic bullet for PPHN. Next slide. So from my limited work with Sildenafil, and I rarely went beyond oral Sildenafil. I did not go beyond 1.5 mg per kilo per dose, 6 to 8 hourly, with good results. The results started within the first dose, but by the third dose, which we gave around 6 to 8 hourly, we found that there was a significant difference in the oxygenation index. So these are the recommended doses by evidence that less than 37 weeks, the loading and maintenance of 0.02 milligram per kilo per hour. Noting the point that the volume of distribution in a preterm baby is much different from a term baby, and term baby is much more different than a full-term adult. So more than 37 weeks, the loading is around 0.13 milligram per kilo per hour, and is administered over 3 hours. And the maintenance is 0.07 milligram per kilo per hour. The target Sildenafil serum value must be at least 40 nanogram per ml. This has not come out in many studies, but Robin Steenhorn, 2006, almost 4 years after my study in 2002, she did the IV Sildenafil study, which I'm coming to shortly. Next slide. Now, this was my initial work of 2002 from Amrita. It showed a dramatic fall in the oxygenation index over 10 to 12 hours. In all those index cases, the first 15 index cases I took were they didn't respond well to INO. So, or INO was not available at that point in time, or the INU had suddenly got discontinued, which can happen very much in our setups. But suffice to say, it produced an impressive drop in oxygenation index. So this study was published in 2003. Next slide. Next slide. After me, almost in 2004, 4 years after me, Baccaro and Sola in South America did the first randomized control study with oral sildenafil in PPHN and found dramatic changes in the oxygenation index by at least 20-25% over a period of time. But at this point, I would like to emphasize the fact that sildenafil is indeed a good molecule, because by the third dose, we are internally confident that we can bring the FiO2 down, or we are confident there'll be no flip-flop, and we can safely work on the ventilatory parameters step by step to back off to prevent oxygen-induced injury, hyperoxia causing superoxide and those free radicals. That injury can be reduced over 24 hours based on this huge study which came up by Sola and my own intimation with sildenafil for the last 20 years. We felt internally confident that we turned down the dial with ventilatory pressures or FiO2, which FiO2 was more interested. Nothing much happened. Next slide. This was a good one by Robin Steenhorn, 2009. We were planning the same study in Amrita, but we all ran away saying, oh my God, the hypotension is too bad, it's a failure. But that was not the truth. The truth was, this has to be given as a loading dose over 3 hours. The new recommendation is to give over half an hour, but maybe about half the dose what Steenhorn used in 2009. So our initial attempts at 2002, which was a failure with IV sildenafil, became proved with Steenhorn when she gave a loading dose after over 3 hours. And that worked in a situation where when they used it without INO, it worked very well. But a caution to all my colleagues in low middle income countries, please don't use it casually, because it has a tremendous potential for hypotension and the whole PPHN balance will be flip-flopped. Next slide. Now, this is my colleagues, Pradeep from Pune and Yogan from US. They did the study which just came out, I think, a month back. I was really true to my heart, because most of the studies don't point on comparing the efficacy of oral and intravenous. I feel that's only subjective feeling. They are almost same. But I would be extremely happy if the serum levels were compared. And I think a serum level about 40 nanogram per ml should be a target in which we say, okay, I feel very confident we can turn the dial down with FiO2 and later the pressures. Next slide. So this is the biggest study from South America by Augusto Sola and group, which I fall back upon. This showed to the world that in low middle income countries, sildenafil is a wonder drug. So this is 2006 and beyond that, in which in one area, he has seen that the INO survival was around 62.5%, a huge, what do you call it, statistical number. And with sildenafil, the survival is almost 60%. This is a study which is very close to my heart, because this is exactly what I felt in the first 15 years with sildenafil. So you have a good molecule sitting here, and the whole world was in a question mark. Was it only a fluke, or was it a genuine study? And this was the second big study which reinforced my thing that the sildenafil really worked in this situation and consistently worked. Next slide. So these were the Cochrane by Shah and Olsen in 2017. One more has come after that. All agreed to the fact that it increases the PaO2 and oxygenation index without much complications. Next slide. So the bottom line, the PaO2 increased by 15 to in 24 hours. Note the time frame. The oxygenation index decreased by 24 hours. So the third dose was what I speculated almost 20 years back, which is in time, most likely with the serum level touching above 40 nanogram per ml. And impressive was that the mortality decreased. This is, I have to agree with this, that after we use Sildenafil in Amrita, my use of nitric oxide was only once or twice per year. We dealt with almost 3 to 4 cases of PPHN referred from outside and internally also every month. Next slide. So this is a systematic review in pediatric pulmonology, April 2021. 8 studies were included, and all came to the thing that OI steadily decreased. P effects after 72 hours. So this is important for us. When we start weaning down nitric, or we start weaning down the FiO2 or any other parameter, the pulmonary vascular stability helps us to wean the kid off the ventilator without any rebound, which we see in nitric oxide. That's why we wean the last 1 part per million of nitric oxide very steadily over 4 to 6 hours. So this again is a very important point for LMIC, and no clinically significant side effect, which in tandem with my observations. Next slide. So these were some studies by my colleagues in the last 10 years, Sildenafil with INO versus INO. And Omar showed that thing that no stats will. So that when you use Sildenafil and INO, which work on almost the same pathway, there is not much of a difference in the oxygenation index changes. Whereas when you use 2 different pathways, either it is to do with your CAMP or GMP or endothelin pathway, there is a very good chance that you will find A plus B is equal to C, a good and a better change in the PaO2 and the oxygenation index. So sildenafil and magnesium sulfate also that they showed that decreased PAP, but in view of the hypotension, all of us are worried not to use it. And sildenafil and iloprost, 2 different pathways. You're using the CMP pathway and the GMP pathway. It did well, but there was a tendency towards systemic hypotension with iloprost, and it's not available in India so freely. Fatima used sildenafil and bosentan, 2 different pathways, the CMP, the GMP pathway and the endothelin pathway, and reported better improved oxygenation. Gandor and group combined with milrinone, that is the 2 different pathways and found. So I think the bottom line is we are in a conceptual model where we can introduce 2 different pathways of the pulmonary vascular resistance thing for better results, keeping in mind that do not use something which can precipitate hypotension. The biggest double-edged sword you're playing with in pulmonary hypertension is hypotension. If you get hypotension, then your whole balance is shifted and you will go into a spiral. It will be difficult to come out. So the moment we do this, friends, I recommend in the LMIC or anywhere, even in advanced countries, feel the posterior tibial pulsation. That tells you entirely what's happening to the baby all the time. You may not have invasive monitoring all the time, especially in HFO. The invasive monitoring may not be good because of vibration. So whenever you have a change or as a reflex, when you auscultate, feel the posterior tibial pulsation. Which is good. You're doing the right thing. Continue. Next slide. So this is a summary of how we should proceed if you have the luxury to do an echo, which is a standard requirement whenever we deal PPHN. So if you have PPHN, you cannot be in a fool's paradise and say, okay, I may be lung problem. At least 10% or maybe more the times, you may be dealing with a cardiac problem, or you may be dealing with something which is a little bit complicated. But suffice to say that in LMIC, be wary of these combinations, but proceed with the treatment. So if you have ductal dependent circulation, like tricuspid atresia, again cardiac echo, pulmonary atresia, you have to go and give prostaglandin E1. It's obvious. Now, the PPHN which we see daily, around 75-80%, meconium aspiration, pneumonia, and sepsis, you have to recruit lung well. That's a primary this. Try to use inhaled pulmonary vascular, which we don't have in India. Go to Sildenafil. I'm sure in the 75% of times which we see in the LMIC, we don't have access or we can't do frequent echoes. You do some good ventilation, recruit lung volume, optimize the cardiac preload, and then give Sildenafil. The other combinations are a little bit rare. So if you have pure PPHN due to lung parenchymal problems like MAS or pneumonia, just lung recruitment, either with a good end expiratory pressure or high frequency oscillation, most of the times your pulmonary vascular resistance will change, as I showed in the earlier figures. This is the rare combinations which you see. Around maybe less than 10% of the time we see every time we feel pulmonary hypertension, a complicated ventricular physiology. Like you have something to do with the left ventricular dysfunction in CDH or some other situations where the ventricular is under enormous strain. This is probably a situation where we may have to consider Mildenhall. Whereas in this situation where you have pulmonary venous hypertension, like TAPVC or a failing left ventricle, wrong thing to use nitric oxide or even Sildenafil because you just flood the lung with pulmonary edema. So with these 4 categories of lung and cardiac hemodynamics, in my limited experience with this over the last 20 years, I will say that 75% of the time, you may be relatively confident to say, I'll recruit lung volume. Okay, I don't have Sildenafil or iloprost. I'll use Sildenafil. And I will use Sildenafil early. I'll come to that later. Next slide. You can go forward. I think nitric everybody knows. Maybe getting bored up with nitric. Next one. So the PPHN and HRF above 34 weeks. INO is indicated for treatment in and the need for ECMO. Okay, we know all that. Contraindication, CDH, left ventricular dysfunction or hyperplastic, that is ductal dependent systemic circulation, or methymenoglutamic. By and large, nitric came in for last almost 22 years. We're reasonably happy, but it's a costly drug and not freely available. I already gave the statistics about the number of centers having unlimited access to nitric oxide. Next slide. Next. So oxygenation index more than 25, you all know. But friends, I strongly suggest that when you want to treat PPHN, please start with the oxygenation index of 15. When I did this thing almost 15-20 years back, I started with the oxygenation index of 25. But if you have echo evidence of PPHN, either hemodynamically from your echo, please start your treatment at an oxygenation index of 15 and try to maintain FiO2 around 60%, because beyond that, the chance of free radical attack of the lung and the spiraling of the whole disease process can occur. So our target is to keep the FiO2 between 70 and 60% all the time, ideally below 60%. Next slide. This is Satyan's diagram of 20-20-20 rule. I think we heard it a lot of times. So if you have nitric, just be careful about weaning, and just be careful in the last 10 parts per million to 1 part per million. Be very cautious, go down by one every 4 hours, and keep a target. Please keep the saturation targets between 92 and 97, because between 90 and 95, the pulmonary vascular resistance comes down immensely at that saturations. Next slide. So now coming to what I'm going to talk today, the various pathways I already told you. We have at one point the endothelin pathway, bosentan. We have the CAMP pathway by Mildenhall. It's a phosphodiesterase 3A inhibitor, which increases the CAMP level. At the level of the nitric oxide, we have cyclic GMP, which is degraded by phosphate diacid, and phosphate diacid E5 inhibitors is sildenafil. So the discussions will be the permutation combinations of these drugs, and there is no magic bullet. Even INO is not a magic bullet, which we thought almost 20 years back. Next slide. So when we treat PPHN, this is what I did. But I have to fall back upon history, that nobody impressed me much more in history than Professor Wang in Columbia. He was a great guy, you know. So when I learned about pulmonary hypertension in the 80s, late 80s, we were madly hyperventilating the guy to get a CO2 at 25 and 27. We didn't know that it could cause deafness and PVL in the brain. And that was taken as standard with tolazolone. This is the 80s. Wang came somewhere in the 80s and told, hey guys, don't bash the lung. This word impressed me so much that all my ventilatory strategies in the last 25 years is based on what Lung just said in 1985. Don't bash the lung. That means don't be too stuck up about a CO2 value of 45, 55, etc. Or even a peak. Just have some chest movement and air entry. So that was a fantastic statement. We guided my my treatment of children, and I think in PPHN also we can apply it. So just be careful that you get a saturation above 92, 90%. And I have worked with PaO2 50 and 55 and got the baby out. So don't have to rush to get a 70, 80, which we did in the 80s. You have to be happy that, okay, we have a PaO2 50, 55, sit quiet, go back and do your 1, 2, 3, 4 and see, okay, my chest is moving, okay, air entry is okay, my blood pressure is okay, you know, put is okay, lactate's okay. Sit quiet. The biggest determinant of the success of the baby come out of PPHN is you. The moment you go home, when a baby is sitting on 100% oxygen, the baby will not do well. Because you must ask yourself, are you the most competent person to deal with PPHN with F5 to 100 and you go home and remote control the kid? No. Which books don't say is that the biggest variable which controls the future of the kid is you. So whenever a baby sits near 100% oxygen, please don't go home. The next 24, 48 hours, you can recover the child before going to a spiral if you sit by the bedside. Next slide. So this is a brilliant this thing by Satyan, which showed that the saturation index, this came in the last few years. Brilliant. So our target saturation should be somewhere between 90 and 95. The pulmonary vascular resistance falls dramatically. But your target should be between 92 and 97 because the alarm limits take some time to respond. Next slide. So this was a first time we did HFO in India was in 1997. I trained with Martin Kessler, and this is in fact Kessler's diagram, which we have been reading from Abu Bakr and Kessler, how the lung volume can be optimized. It's $1 million question, okay. So this is the sine qua non of ventilation. How do you optimize lung volume? Because if you see, or I can see our colleague here just waking up, I can see him on my camera. He will say this lung space only eight spaces. Whereas you sitting far away, I'll say there's 9 spaces. And somebody sitting the bedside will say, sir, it's only 8.5 spaces. So where is the objectivity translating into true performance? No, we don't have one. So if you are in the bedside as the head of department, you can take the call. Yes, I think it is 8.5 spaces. The diaphragm is flat, blah, blah, blah. And the number of spaces, that is a very vague thing which is subjective. Now, in this high-tech world, which I don't like, next slide. This is the good one. We are sitting somewhere in the upper part of pressure volume curve. If you have an A and B lines, watch it carefully. So if the A and B lines are okay with you and the B lines have come less, you are sitting on the optimum part of pressure volume curve. You're not doing it above. The moment you go in the beaked part of the pressure volume curve, especially on HFO, you will volume deplete the child slowly. And you will have again another fall in the pulmonary vascular resistance and PPHN. So to optimize lung volume is a central point of the management of PPHN. You cannot do without that. So X-ray is only a very vague, subjective thing which can change with time. You can do bedside ultrasound frequently, and you can optimize your lung volume. Without optimizing lung volume, no inodilator, nothing will work. Hemodynamic, nothing will work. Next slide. So this is a nice slide by Satyen, but suffice to say that if you have a PPHN with a lung parenchymal problem like pneumonia, sepsis, meconium aspiration, please use surfactant early because of the various anti-inflammatory properties it has, and in fact it functions as a relative modulator of the PGE5 enzyme, which degrades your this nitric oxide. So if you're using surfactant, use it early. Surf the kid early. Next slide. So hydrocortisone, you have to be very careful because it's a magic bullet. Be careful about sepsis. But suppose you say, Dr. Rajiv, you have been handling this PPHN for quite a long time. What's your feeling? This I discussed Satyan also. If you feel that you're sitting on FiO2-1, meconium aspiration, there may be sepsis parameters positive, and your antibiotic cover is good. I think that should be offered because you're sitting on a wall in which your FiO2 is 1. You don't know where to go. Your PiO2 is 50, 55. This I have used almost 15, 20 years back with good results. But the evidence-based side, you must see that in infection, it will be extremely the double bullet. Next slide. So the only relative contraindication for INO or sildenafil will be ventricular dysfunction or a ductal dependent lesion in a cyanotic heart disease, etc., where the opposite effects occur. So if you have a TAPVC with pulmonary venous hypertension, or you have left ventricular dysfunction, or in fact even right ventricular dysfunction, the drug of choice should be milrinone, but your blood pressure must be normal. Because our own experience with milrinone, whatever I talk to Patrick and whatever he tries to evidence-based, I must say that don't use milrinone when there's hypotension. Next slide. So this is a Patrick study, a brilliant study. It's actually a good drug, and I think it should be used in the proper context. You must select the ventricular physiology and the lung problem, and select and use it in when the blood pressure and hypertension has been controlled. Otherwise, you'll go into a bad spiral with the hypertension. Next slide. Now, ET receptor thing, which is, if you go back historically, Ambalwanan from that group in USA, he was the first to use bosentan. It's almost like 2002. Somewhere along the line, this new drug somewhere fell out. But I was very happy when Daniel DeLuca used it in his article to in the refractory PPHN to INO. I was very happy he mentioned. I still, in my heart, somewhere is there, but I have not worked with this. Kiran Moore has worked with it, and he found it was a good one. I still feel the final thing is not out. Steenhorn, who was with this sildenafil, IV sildenafil, and an excellent researcher, she didn't find any improvement with bosentan. But I have a strong feeling we're not selected the case properly, and I think we should add it. If Daniel DeLuca from the European network took it as a third-line drug for refractory INO, I think we should give it a serious thought. The bottom line is not out. I think Kiran may be right in the long run. Next slide. So inadequate. This is all. So many studies come. You see, this is CDH may be appropriate with CDH and BPD. The ventricular physiology in the lung may be different. It takes time. The absorption is a little bit erratic, and the steady state takes around 5 days. So maybe there are combinations which are to use, like you may have to use first sildenafil, and because there are two different pathways. Like I told, A plus B is always better than A plus A. So this is A plus B. Next slide. There is Steenhorn in that future 4 study. Next one. That's a RCT. Next one. So PPH and CDH is a totally different. I'm not able to spend time on it. But let us say from my limited experience in Amrita, our survival was almost 83% without ECMO. So we used to deal with at least in 4 months 2 CDH, which is pretty good as we were a referral center. Again, Sildenafil worked in these cases with optimizing the lung with high frequency oxygenation. We offered that, good preload and good pediatric cardiac backup. We had a good backup of pediatric cardiology unit in Amrita. So our survival is almost 83%, and we used to operate that kid in the NICU. So the meticulous detailed planning in CDH is very, very important. You cannot leave that I transport that kid to the theater and come back. Even that single transport is dangerous, especially on HFO. So if you feel that you want to do a good job with CDH, have a small, in the future, plan of a theater in the NICU. That makes a tremendous difference to this kid, because transport, the tube getting slightly kinked or blocked, the fall in the pressures when you transport a kid on HFO are different. We in Amrita we used to operate a kid on HFO inside the NICU, and that may be why it contributed to that 83% survival without ECMO. So here, approximately 20% of the so-called fixed pulmonary hypertension CDH may respond to sildenafil or nitric. So that gives you a window period to do your surgery after maintaining good hemodynamic control. Don't plan and jump on the diaphragmatic hernia on day one. You stabilize the pulmonary vasculature over a few days, get a reasonably good oxygenation index, maybe around 20 or a little bit less. And that window period should be used to operate, because after that it gets difficult. Because whatever chance you're given for that diaphragmatic hernia, there may be some residual lung function to open up. That is lost. If you keep on with your vasodilator and nitric and not take a call, that makes the difference. But I strongly suggest, if you're doing your CDH survival improve tremendously if you operate in the NICU. Next slide. Now, BPD, we all know, I don't think I have to teach much about this, or not teach, I mean to convey. We all know that we use sildenafil in BPD. It's a good drug. Similarly, bosentan can be used in that as an add-on, because there are two different pathways. So sildenafil in CDH is an approved this thing. When you even long-term nitric or long-term iloprost, or even the Western world, it's not used. Sildenafil has proven far beyond what it was initially did in 2000. It remodeled the pulmonary vasculature, maintained stability, and these kids over a period of time could be weaned off the oxygen also over a period of few months. There was a caution on the use of sildenafil by FDA in 2014. But those warning never included babies in the infancy, and was never done for a neonate. So, friends, I am sure this sildenafil can be used, and just make sure you keep an eye on the retinal vessels when you're doing that. But generally, it's used close to 1 to 2 months post-conceptional. So it may be in a safe period even for the eye. So let us conclude saying that yes, we can use PPHN in BPD, sildenafil, and you can add on bosentan. Next slide. This I already discussed. Next one. Now, when you come to, so at one point I have discussed very clearly how to recruit lung volume. What are the ingredients to recruit lung volume? And the targets for CO2 can be anything like 45 to 55. Sometimes I have sat on 60, 65 with the diaphragmatic, provided the pH remains above 7.25. 7.2 you can accept after a week or so, because it triggers off pulmonary vascular resistance. So in clinical practice, pH 7.25, the acute phase, maybe after a week you can use 7.2. By the time pulmonary vascular is stabilized. So all this we have summarized now in a nice way. And next slide. So I'm coming to the final part of my talk. So in PPHN, there's nothing left to chance. You don't have a second chance. So the first question is, who's the most qualified, experienced man to handle PPHN? The head of department. So That responsibility cannot be shared even on telephonic calls, because the understanding of the baby in the bedside is the most important determining factor of the child's survival. So in those days, I know Manoj, VC, and Nalnikant all know that I sleep in the hospital for 3 days. There's a reason for that. When I see the chest movement, or when I see the posterior tibial pulsation, I know something is not right. That may not be easy for a person who has just become a registrar or maybe 5 years. It takes a lot of time to see the chest movement and say, okay, I think in HFO, the map is going down, or he needs ET suction. A wrong ET suction on HFO will completely put the baby into wrong spiral. So the assessment of a baby with FiO2 is by you. Don't shirk that responsibility. Then come all these parameters. Okay, I'm seeing the blood pressure, keep it around above 45. I'm seeing the pH, keep it above 7.25, later 7.2. There are so many battles I fought at the bedside with the FiO2 and never gone home. So the point is, there are so many small things you can do. You can increase the blood pressure. You can don't do suctioning, because I felt the tube was properly suctioned. These are the turning points of the kid the first 3 days of PPHN, which is the most dangerous period. Then later, coming to what all of us know, gentle ventilation by Wang, my favorite, God bless that man. He changed my thinking. Then early surfactant, already told you. Hydrocortisone, please use early. In those circumstances where you feel sepsis is not the primary issue, then you divide. Now you're gone to one side as, okay, I've optimized lung volume, hemodynamic, blood pressure. Now you want to know the hemodynamic part, which I discussed with Patrick and Satyan. So you have 3 types of this one. Like you have RV and LV normal, you have LV dysfunction, and in which you have subcomponents like systemic blood pressure normal, low, or systemic blood pressure. So the 3 types of ventricular physiology you have to address when you come to second phase of your management. Next slide. So in this, all of us knew, but I'm just recapping this because it's from the latest article I've seen from Satyan and the new ones I read. These are something not extremely familiar with me because we were in a different era, but suffice to say, they are very important. But as an old timer with this pulmonary hypertension, in which 70%, 80% we can do at the bedside LMIC, the feeling of the posterior tibial pulsation is the most important bedside sign when you're dealing with PPHN. Time and again, that has saved me. If you feel the posterior tibial after 4 hours, I don't feel it's so good. Maybe your mean blood pressure is coming low, or the lung is improving and your MAP, mean airway pressure, is getting too high. It may not be reflected on your invasive blood pressure monitoring. So these are extremely important signs that whenever you do high frequency or any type of resuscitation in a baby with PPHN, feel the posterior tibial pulsation at least every 4 hours. That gives you the solid clue. Despite whatever of these things which came up later, I still feel those basics have to be adhered to. So you have pulmonary artery pressure, pulmonary vascular resistance, and the systolic time intervals. You have right ventricular performance, shunt, and you have this TDI, tissue Doppler injection and ejection fraction. All are okay. Next slide. This is a good one to see the septal deviation with echo. So from these things, normal curvature, moderate pH, and severe pH, the septal movement, septal bowing tells you, along with this, if you combine the tricuspid regurgitation jet, by and large, you can pick up the pulmonary artery pressure if it's above 25 to 30, or the pulmonary pulmonary on the higher side, you can make it out from the bowing into left ventricle. Next slide. So now I come to the second part, the last part. The standard drug to start will probably be adrenaline. In a not a very high dose to cause beta effects. You may stop it around 0.01 mic per kilo per minute. When you go beyond 0.1 mics per kilo per minute, Be careful, because this is a wide range. The moment you say adrenaline, after you use adrenaline, the next choice to me may be vasopressin, because the effects on systemic circulation, the heart rate, and the systemic blood pressure are not that thing. Only thing you have to keep an eye on is sodium. But before we do all this, friends, feel the posterior tibial pulsation and correlate with your preload. So before you do something, if the preload is good, you can wait and watch. Similarly, whenever we use any of those drugs like sildenafil or iloprost, anything which can have the potential of hypotension, please prime the kid with 10 ml per kilo saline over half to 1 hour, and then do these things. In that limited experience of mine of almost 20 years, because maybe the rarity of those conditions like TAPVC, venous hypertension, and left ventricle failing were less. They have helped me to pull the kid out of the trouble. So adrenaline, preload, check it, 10 ml per kilo, use cautiously, go to adrenaline, medium dose, and add hydrocortisone if there's no sepsis. Meantime, if there is LV or dysfunction, add milrinone. But now the milrinone dose is half what was used 7-8 years back by Patrick. It's almost half the dose. And generally try to avoid loading with milrinone. Dopamine is okay. I've not used it that much. And vasopressin is probably what I feel we should do, and what Patrick McNamara strongly feels. I feel that we have to follow up on his experience, use vasopressin. I've not used that much, but I think it's a good one. The new units are all using it. And the various permutation combinations I already told you, flavored with my own experience on the bedside with this. Next slide. Last few slides, which will be. So the various combinations are there in this slide. If you have normal RV and LV function, of course, then sildenafil, nitric oxide, all will work. Systemic thing, epinephrine, vasopressin. RV dysfunction, you have to be careful. LV is normal. You have the combinations here. Okay. And LV dysfunction and RV dysfunction, then of course, milrinone, provided you maintain the blood pressure. Be very careful. So in my limited thing with this, let us say first preload 10 ml per kilo, then optimize the lung volume, use ultrasound, be in the bedside, don't go home. The next one is which inotrope based on this simple table given to me by Satyan. I think it's a good one. I asked him, I want this because some of these other molecules I'm not expert. Bosentan I have not used. But I strongly have a good feeling on Bosentan. Honestly, it is not so simple like one study disproves it and all that. We have to have a larger volume and a proper RCT, which bigger thing. I have to agree with that. So epinephrine, vasopressin, posterior tibial pulsation. Next slide. Future directions. Okay, next slide. Next one. This one I'm not going detail because it's only for the postgraduates. All this ROC inhibitors, then this soluble guanyl cyclase, what do you call it, analogs, and facilitators, citrulline. I'm not going detail, but I'm just saying they are there in the arena, but not come into proper clinical practice. They're promising. Next slide. But what is more interesting I wanted to present today is, did Viagra protect the brain? So for last 10 years, with my follow-up of the babies for almost 10-15 years after I gave Viagra, almost 25 in the series, I found that they were superbly, the neurodevelopmental was normal. I did that first for the sake of following up these kids, because that time it was an experimental drug. But I must say that many of these, next slide. Next slide. So this is our thing in which our SNAP score was pretty high and the oxygenation index was sitting near 35 and 45 near ECMO zone. Most of the children who are in this thing, in this zone, did extremely well on neurodevelopmental follow-up at 5 to 7 years. Next one. Next. So these were the controls. Next one. 5-year neurodevelopmental follow-up so far not done. I'm going to publish it. Myself and Nalinikant want to publish this because it is in tandem with the animal studies now. In the last 10 years, when I spoke on this, everybody looked at me the weird eye. So probably this molecule will be the standard of care. Once it's proved it's got neurodevelopmental neuroprotection, it may be a standard drug to use even for PPHN. Next one. So just to recap, friends, thank you for listening patiently to me. And why this conference is unique to me, because I first started the ventilatory care in Kerala in 1992. This is the first baby saved in 1992 in Kerala in that hospital, 28-weeker. Then I went on. First 500-gram baby in India was saved by me in 1997. 22 weeks and 5 days of 17 years infertility. He has gone to college. He's not the brightest of the students, but he has gone to college. That much I have followed him up. Next one. I hope many of you will have read our books. CPAP bedside application, one of the first books in the world, 2008. 2018 was my textbook. Myself, Vidyasagar and Satyan. This is the next book coming next year, Essentials of Neonatology. Thank you for patient listening. And I'm glad I could flavor this lecture with my own personal intimacy with Sildenafil and etc. Thank you very much. Good day.
Thank you, Professor Rajiv. That was a wonderful talk. Again, highlighting the importance of sticking to basics before going on to really costly medication followed abroad. We have our own limitations, but with our limitations, we are able to manage babies as you have done 20 years back. That was very reassuring to know that from the horse's mouth. Very good. Just wondering if there are any questions. I think you've dealt it very well. I'm not sure there are any questions. Any questions?
But I woke you up. That is important. I was watching you very carefully as a control. Because always in a lecture, you were a good control for me. I could watch you very carefully, and suddenly you were in between. You were getting up and say, "Oh, that is good." If you were dozing away, it was not good.
Every slide was an interesting point for me to wake up.
No, but slowly you were drifting off, but I could get your attention back. That was you were lucky you were sitting as my control.
Anyway, so anybody like to ask any questions at all? No, I think I think that the talk was so good that people actually don't have any questions to ask. But I think the point is well noted here that we'll stick to basics, do our ventilation properly, take care of the hypertension before moving on to medication. And if done properly with the proper medication, especially with the help of either trained echo or cardiologist, this is a problem which can be very well managed and also managed effectively, cost effectively as well. And thank you for.
Can I speak something?
Yes, please.
See, I tell you, in LMIC, echo may not be, it may be luxury sometimes. So we have to fall back upon the bedside practice of feeding the posterior tibial very well. So whenever I train my students, including Nalinikant and Manoj and all that, the posterior tibial tells you the huge story. The fact the posterior tibial is well itself means that your circulation, including your pulmonary hypertension or whatever may be, you've done the right thing. Maybe after 4 hours, things may be different. So the chest movement, your urine output, your lactate, and the posterior tibial pulsation again tells you, along with improved oxygenation. So sometimes in ventilatory strategy, you have to do 3 things. Don't do anything. That means itching to do something which is not appropriate at that time is dangerous. That comes with experience. Secondly, sitting on the fence. Okay, you are reaching a FiO2 of 1. The map is sitting around 28 on HFO. And your urine output is okay, posterior tibial is okay, mean arterial blood pressure is okay, chest movement is okay, air entry is okay. Sit quiet. That means you're sitting on the fence ready to attack if there is any deterioration in those signs. The third one is now you're recruiting lung volume in the first 6 to 8 hours of say RDS or meconium. Meconium may take time, it may take even 24 hours. You have to recruit Because if you don't recruit that time, you have missed the window. So suppose I'm sitting on and the lower part of pressure volume, the chest movement is not so good, the CO2 is not good. And friends, take it from me, the only thing you have to worry about ventilatory strategy is your end expiratory pressure. Don't worry about a peak inspiratory pressure, tidal volume, eye time. If you optimize your lung volume well, like I showed you, the lung ultrasound is a luxury for me, your entire ventilator strategy will determine success. So if your end expiratory pressure management is wrong, suppose in the 80s, we were ventilating with low PEEP and high PIP. That was a strategy in the 80s and even 90s. I still think some units are doing that. Don't do that. To improve MAP, don't increase PIP and reduce the, and don't go up on PEEP. When I went to high frequency oscillation training center in Iowa in 1997, I got a shock of my life because they were using very high end expiratory pressures. High means in my mind. They were using end expiratory pressure 5, University of Iowa. I hope you know that they are dealing with 22 weekers. And they save almost all 22 weekers. They save. So I got a shock of my life in 97 when I went there. Then I realized what Wang told and these great people told me is that the only thing you have to worry about your ventilatory management is your end expiratory pressure or MAP on HFO. 1 centimeter change in that can completely either take you up the pressure volume curve or put you in a spiral. In 1990, there were 2 trials on HFO. One was Hi-Fi and was Hi-Fi. That showed the world that if you don't recruit MAP on HFO extra 2 centimeter and then play with low MAP on HFO, the outcomes and ventilatory outcomes are totally different. So that was those people who taught me. I'm telling the young fellows here, don't hesitate to go up on 1 centimeter extra pressure if required. The other way around, suppose you feel you're really sitting on the upper part of the pressure volume curve and you're slowly losing oxygenation. The question should come in your mind, did I use too much end expiratory pressure by 1 centimeter of water? That 1 centimeter of water is critical in the ventilatory strategy. So don't play with MAP, I mean end expiratory pressure. I'll put 1 and see, don't do that. You have taken a educated guess that yes, I'm going to put only this much because FiO2 is 60% or 70%. It is a CPAP, PEEP of 6 or 7. Don't change that. Once you have fixed your end expiratory pressure in your mind and as per your experience and now lung ultrasound, then only you work on the PIP and tidal volume and eye time. Somewhere along the line in PPHN, 10 ml per kilo bolus is required. So suppose we are in a situation, I'm not sure, at night, 1 o'clock, the child's urine output has come down. The lung has improved because it's meconium aspiration. Now you don't know what you should do. You're still sitting in 90% oxygen, you're 10%. But will I lose the 10% if I bring the MAP down will be the question. So in that situation, maybe 10 ml per kilo slowly volume over some time. And if oxygenation improves, you have won the battle because you're very carefully played with the hemodynamics to your advantage. Then you drop the MAP. If it's maybe came down again by another 5%, you drop and he did very well. That's because you have used a very proper strategy to get your end expiratory pressure down. The whole ventilation in the last 30 years for me, I'm not worried about your PIP or eye time. I'm only worried. I only ask one thing in the rounds. What is the end expiratory pressure you used? What's the MAP on HFO? They are the outcome determinants of your strategy. So at night, these things come up between 11 p.m. and 3 a.m. Oh, am I sitting on this part of the pressure volume curve? Maybe lung ultrasound will help us because we don't know where we are sitting. And the lung has improved. Suppose meconium aspiration or RDS or pneumonia, the lung has improved. So time has come to back off. So the back off should not be unphysiological. It should be physiological to that lung at that point in time. And if you've done the right thing many times, oh, the PaO2 just opened up. The PaO2 comes up from say 60, 70 to 120 because you have reduced the MAP by 1. And in the process, the air entry and the tidal volume has changed. And on HFO, the volume which goes down to your lung, that has changed. So these are the intricacies of things which we can't teach in the bedside. So PPHN, FiO2 1, if you are the head of department, be in the hospital. Take it from me today. If you, as a control study, 10 units take this and 10 you don't. Okay, Dr. Rajiv's thing. Apart from this algorithm which I'm going to give for the world, this is the turning point in ventilative strategy. So Manoj and Nalikant, all who are with me, they know Dr. Rajiv will be there. Don't worry. He'll always be smiling because he knows what's going to happen. Okay, that's a story. Nice story.
Excellent. I think we have somebody asking a question. Come forward, please. Yeah. Can you come forward?
A very good morning, sir.
Morning.
I'm Dr. Aisha. Basically, I'm a pediatric surgeon working in Amrita and heard a lot about you during my training time and by Dr. Girish sir also. And this PPHN we are dealing with like in cases of congenital diaphragmatic hernia. And I was wondering whether sildenafil will be effective for that. And you, that thing well taken in your presentation as well. And this PPHN is also close to my heart because of a lot of cases in congenital diaphragmatic hernia. We deal with it. And the other thing, a good message you gave, and we are still following it, that we are operating those critical cases in NICU itself. And we are sticking to our good outcome of diaphragmatic hernia to that 83 and above.
Aisha,
yes,
see, you won't know, but it's important that whenever Mohan Abram, your head of departments, operate, he'll never operate without me. So the point is not that I'm a great guy. No. The point is, I am the most experienced man in the unit to be with the diaphragmatic hernia. You see the point? So at the bedside, the finer things we do. When Mohan and me operated, we used to operate on HFO in diaphragmatic hernia. That's not a joke because you're operating on a diaphragmatic hernia in the theater is one of the worst situations you ever land up in your life. And we had the best survival in the country of diaphragmatic hernia. I think almost it was published by Mohan Abram. We had the best survival of diaphragmatic hernia in the country. So the hard work of Mohan Abram, myself, and the ventilator strategy, nursing staff, the doctors, unless you as head of department fall into place with discipline and sacrifice, it will not change. You can't remote control a diaphragmatic hernia or a PPHN at home with FiO2 You cannot. But people are doing that. So I say I'm happy the tradition is continuing. I think Mohan has retired, but that was a fantastic man. I worked with him for almost 30 years.
He's still there. He's soon going to get retired, but we want him to be there in the department.
Yeah, and then he'll want me also. Then he has to pull me also there.
Yes, sir, please, most welcome. We'll be lucky enough.
It's great Amrita is doing well. Because I'll tell you one more thing. Since you mentioned that, we had the best survival of PPH in India at 90%. Term baby was 90% because of the various strategies I told the young man. Sit on the fence, then take an aggressive stand to recruit lung volume. Masterly in activities. We'll select the case to do these three things. 75 to 80%, whatever we did in Amrita was good. The 10% is all the complicated ones we saw. The left ventricular dysfunction, the very high right ventricular tension in which we had to use prostaglandin even to decompress the right ventricle. These were very exceptional situations in a year in Amrita because we used to deal with at least 2 PPHNs a month. And our diaphragmatic hernia was very, very high. I think we operated on 54 cases in 4 years. We had a big series of diaphragmatic hernia. Correct, no?
Yes. Now it has crossed, I think, more than 200 plus.
Yeah. So I think we are in a point to say some message to our friends. And conference is always learning, bilateral learning. Now I learn from Nalinikant and VC Manoj. Sometimes I ask them because I am not geared with this lung ultrasound. We never grew up with that. But I have to accept that technology has changed and recruiting lung volume optimally in HFO or anything is the primary event. If they can use lung ultrasound to fine-tune the optimum lung volume, it's a great thing. I think they've already done it. When I spoke to Nalinikant today, he told me A and B lines and all that. And I said, yes, Nalinikant, I think we should go that way. Correct, no? Similarly, artificial intelligence. So sorry to diverge, but I tell you, I gave a message to all the youngsters today, and I hope that all of you woke up. And that's all I want. At least you woke up and you are now in the weaning mode for lunch.
Thank you, sir. Thank you so much, sir.
Right.
not just about waking up, you have also made me lose my sleep at night with the PPHN. Anyway, thank you so much. I get the message. I think we all got the message. But thank you for reiterating that again. Thank you for coming
Thank you.
on,
Thank you.
Professor.